So I first would like to thank everybody for coming today, for staying this, and I am really ticked off that I have to follow Majid. So that and that I'm being forced, and this was what was said, can you actually present some real science? I said, well, that's boring. That's not this group. That's when I want to go put people to sleep I don't like. So, it's smiles or something. So I'm actually going to talk to you about some real science, and I'm going to try and walk through you, those who are not familiar how we do this, why this is completely unimportant. And most of my research over the years really focuses on physician uncertainty and nursing uncertainty, that everybody will behave differently in unclear situations, and that people will behave in such a manner to say, well, if there's no proof, I can do whatever I want. And I like watching when people do whatever they want and see what happens to patients, because that's sometimes a really good way to learn. Now, I am very honored by those, to be here knowing that how you have treated Dr. Malik. And when I got my hand on this yesterday, I was so impressed. And I was reminded what my nurses in Detroit did for my 40th birthday, where they all donned, including the white triangular hats, in honor. Of course, then they also chased me around with a bottle trying to paint me with liquid paper all day. But I was rather impressed by you all. So let's talk about the issue of science. So one of the concerns when you're looking at science is how do you actually determine what it is that you found, whether it means anything. And so, for instance, I can sit and take apples and oranges, and I can find all sorts of things that look like they ought to make sense, right? That, they grow in orchards, they seem very similar. They can be eaten, right? But they have different colors, and so maybe I can go around some way trying to figure that out. And ultimately, when we get to testing, the issue is always, can we do a randomized controlled trial? And if you remember that somewhere back in here that I'm going to talk about this topic, about what happens with trying to prevent venous thromboembolic disease in patients who are already bleeding, then you really start to confuse yourself. And so we have to look for trial methods. And we ultimately want the randomized controlled trial. So that would say, ultimately, take these people who are bleeding in their heads and randomize them. But it's amazing how invested people are in what they do. Well, I can't allow that patient to be randomized to receive placebo because they must have the drug. Right? Well, I cannot allow that patient to be randomized to get the drop the microphone to get the drug because they cannot take that drug. It's too dangerous. So, that said, right, ultimately those who believe in the randomized controlled trial is this somewhat tongue-in-cheek, I'll call it very tongue-in-cheek, but call for a randomized controlled trial. For those of you who believe in this stuff and that we can only learn from these sorts of trials, of a randomized trial of parachute efficacy from 10,000 feet, because there never has been such a study, and that if you really believe in this, you will allow yourself to be assigned to the control group. So what happens really, the bottom line, what happens when we deal with science and presenting this stuff is that you poor people are stuck here. You had a great speaker before me. Pretty soon, lunch is going to come wafting through, and growlings, and you're going to be stuck here with me. Can you lock the doors back there, please? So all I did actually is I'm just kind of a professional cheerleader, and these are a bunch of people who do all the work and then leave it for me to analyze or do this. And we presented this earlier this year at the International Stroke Conference. So again, this is all about confusion. So what do? We turn to guidelines whenever we're looking for something. And so the wise men and women of the American Heart Association, the American Stroke Association, gather together in a lovely room, and they decide that you should have at least, the squeezy boots are good, right? Squeezy boots are good on top of elastic stockings. Now, how many people do belts and suspenders like that? No. So already, don't tell me about the guidelines. None of you were following them to begin with, right? And then it says that low molecular weight heparins or unfractionated heparin, I don't know whatever flavor is yours, if it's dalteparin, enoxaparin, et cetera. I don't use trade names, so you can translate that yourself. And then it says, it may be considered after documenting cessation of bleeding in patients with lack of mobility. Huh? What? So, what do we know? We know that if you give drugs that either prevent or reduce the incidence of clots, that they actually do that. It's pretty good. That's nice to know. But the thing that's not clear is, are the squeezy boots enough? Well, you're not doing it right anyway. You're not putting the elastic stockings on with them, right? So what happens if you do it? And in fact, if you look to available information that I'm not going to show you because I don't want to confuse you from what I want to confuse you about, is that there have been 2 randomized trials that found no difference in either the occurrence of bleeding or the occurrence of DVTs. So why are we even talking about this? Well, because I told you why. He won't let me talk to you about the Three Stooges. So the real question is, if you're afraid, and if you give these drugs in somebody who's bleeding, and bleeding trapped inside this closed box in an uncompressible site, then is this going to keep them bleeding? Well, you know, that's why I don't do it, because they might bleed. Well, they're already bleeding, right? And so what we can figure is if you take a look at some other people who have been bleeding that have been getting these drugs. Now, for some reason, we behave very differently in trauma patients. Maybe because in trauma patients, we have aggressive surgeons, neurosurgeons, neurointensivists that are in there and say, well, and we got these things called guidelines and skip guidelines, and we get graded. And we give these drugs to these people, and we say, wow, only 1% to 3% of them in Europe actually had progression of their contusions. Well, that's not very many, is it? Unless, of course, that 1%'s yours. So at least what we figure out, at least in patients with brain trauma and contusions of the brain, that it looks like this stuff looks safe. But we behave so differently when in comes the intracerebral hemorrhage or the aneurysmal hemorrhage. And so the bottom line is we know nothing. And so what we thought we would do is we would add to the lack of knowledge. Now that's easy. So step 1 is you just stand there and do nothing, right? You watch. Or as the great philosopher Yogi Berra said, you can observe a lot just by watching. And just count the bodies. What do people do? And the beauty of doing observational research like that is I don't have to tell you why, or I mean, I could make up sorts of things. Right? It's like, I don't know, I'm just looking. Just window shopping. And trying to at least see, could we find any kind of relationship based on this? Because a priori, everyone said, we always do it the same wrong way every time so we can control for the error. And I said, let's find out. So what we did is we went back and we took a group of patients. Right? First, you define your cohort whenever you're doing this. Who are you going to look at? You're going to look at patients with hemorrhagic stroke. We're going to do this in over a nearly 3-year period, all admitted to a single level 1 trauma center, which means you get all sorts of other good stuff too, and a comprehensive stroke center. And we wanted to at least have people to watch what would happen, right? If people were going to die in the first day, well, obviously that wasn't going to be an issue. Probably there was something else that was driving their care other than the decision to give them one of these drugs. And essentially then we only had 1 child in there under 18, so we figured just throw, so nobody can say we confused anything, right? And then we threw out 25 because along the line they actually had come back, the readmission. which of course then I looked at, I said, 25 out of 293 got readmitted. That's another study, right? You know, or they were admitted for intracerebral hemorrhage, and when I looked at their CT scans, I couldn't find it. And then I went back to the radiologist's report, and they couldn't find it either. So we figured something got lost in the coding there. That doesn't happen at my hospital. It's been reported at other institutions, right? And then we threw out 28 because somebody else mucked around before we did. They were transferred from somewhere else, not immediately, but more than a day later. See, you suddenly, just looking at one thing, you learn a lot of things about your hospital, right? This goes for any of you. Basically, what I really want to do today is I want to get somebody excited to go down and do some good research stuff, right? Anyway, we got left with 243 people. That's reasonable. We can do that, right? And what do we want? Right? Define what you're looking for. Did they get pharmacological thromboprophylaxis, either one of the drugs? Yes or no, right? Then the real question was, because this is what bothered me. Well, you know, you give it and then, oh, you got to stop it here. No, because you can't give low molecular weight heparins if we're going to violate the dura. But heparin might make them bleed. You have to give it so often. And look, oh, he looks bruised. And, right, what do? We start it, we stop it, we start it. Well, hold it today. Maybe just not give it this morning. Go ahead. Now, where they're a little less confused and a little more rigid, if you look at a Japanese study instead, that there was actually a nice study that looked at people with bleeding aneurysms going to craniotomy, right? Blood everywhere, given heparin before they went. And what did they find? They found that if they got subcutaneous heparin, they actually had less vasospasm. That's a whole other story. God, there's all this other stuff to do. See, getting excited. And there was no increase in the risk of transfusion or bleeding. Wow, that's kind of cool. Why are we even concerned about this anymore? Everything's been prone, right? Then, since the guidelines say within 72 hours, am I talking to a dead microphone here? That did people actually behave within 70 or after 72 hours? And then there's the real question. Whoa, that hemorrhage grew. I'm not giving it yet. Okay, you tipped your hand. You gave me a reason, right? Or did they actually start getting it before then so that it could be blamed, right? We like to assign blame. Well, it's the drug's fault. But the problem here is we don't fully understand what's the natural history of this. Am I doing something wrong? Well, I guess I have to leave now. Oh, no, that's all right. I like it. I'm playing with it. How many of you remember when you had your security blanket removed from you? Kind of bummed now. I bet you miss Majid up here talking. Yeah. So the next question is, did we even have a chance to see, did the hemorrhage progress? But you have to get another CAT scan because we can't keep peering in there every time, right? And then we'd look and see what happened. So we identified two kinds of people. This is the plot thickens. When you get that follow-up CT scan, the hemorrhage is no larger. And the other one, anyone? Bueller? It grew, right? So we already knew what happened. This is so easy, right? There's nothing to this research stuff. And then we have to decide, just because the picture looks worse, whoa, that's awful, right? So you were just listening to a group of people that I can take people with all sorts of senile dementias, and I can stuff 60 cc's of blood into a temporal lobe, and they might act a little confused, or nobody, says, well, it's just grandpa. Right? Or I could take a youngster, not over here, and I can, Madam Photographer, and I can put maybe 10 cc's of blood right in her putamen, and she'll be devastated. So it's not just the question that 60 cc's looks worse than 10. Bigger is worse, not just what you just heard before. So what sorts of things? Well, you know, it has to do with pressure in the head. Fine. Intracranial pressure increased. Anything else? Well, you know, it grew like really badly. Fine, whatever. They got worse clinically. That would be nice to know, right? Or they kept getting worse again and again and again and again. And then we look and watch, right? So why did they get the CAT scans done if they got it again? Did they bounce back to the eye? Well, everything looks fine. Oops, right? And then, did we do anything about it, right? Did neurosurgeons say, let's take this out, or let's do X, Y, or Z? And then, that was one sort of bad thing, right? That you get worse because you're bleeding. The other sort of bad thing is that you get blood clots. So any pulmonary embolism, it's like, hey, you know, that's big and bad. We're just going to call that big and bad. But we got to go looking, right? Are there thromboses elsewhere? Steve Kramer did I loved it, you know, for the acronym, the pelvis study. It took a bunch of stroke patients and put them through MR venograms and found, well, you know, these ultrasounds of their legs, they don't have any DVTs. Well, you go looking in their pelvic veins, and yes, they do. And then if you go, depends where you look. If you go looking in the neurology literature, the critical care literature, the neurosurgical, well, you know, it's about 4% of the rehab. And if you go looking in the rehab literature where they go looking, it's over 11% of these patients have clots in their leg. You just didn't look. So there's a lot of confusion here. Now, the problem here is that this is retrospective. Again, I only can look at what we got, right? And screening was not routinely performed in these people. So anybody who actually had a clot, it was because of symptoms. Okay, I seen the first yawn today. Excellent. Don't be self-conscious. I'm not really watching. Right? And then we figured that there's other things you want to look at. Maybe these matter. We call them covariates, or we try to control for when we do this are confounders. Things that may be true in addition to what we think is true and that may actually be the right answer. So does this have something to do with gender? Aneurysmal subarachnoid hemorrhage is more common in women than in men. Does this have something to do with age? Intracerebral hemorrhage tends to be more devastating and occurs younger than ischemic stroke. Aneurysmal hemorrhage is a nice middle-aged disease. In fact, I'm right at the median age right now, but I'm not female. Ooh, personal information. Did it make a difference? Were people sending us people who were worse off or versus everything that rolled in the door? And then, what if they were taking blood thinners already, right, of something or another, or other platelet stuff? We couldn't deal with anti-platelet drugs because the whole world is taking them. As was suggested for dementia, did something about body mass index have anything to do with it? Did it matter what kind of neurological condition you showed up? Did people behave differently with you because you're in good shape versus, ooh, he's comatose, that looks bad, right? And then make sure that we're doing the other things, those squeezy boots again. And then, I know what you really want to look at is all the statistical stuff here, so you can memorize this and have your answers on my desk in triplicate first thing Monday morning. Yeah, let's skip that stuff, okay? Does anybody really want to know about adjusting this for associations? No, good. That's why you should go, unless you're insane like me, go find when you do this, a good statistician, somebody that's got MPH at the end of his, her name, right, and say, help. So, anyway, what did we learn by looking at all this? Well, we learned we were pretty good when you look through these 245 patients across these couple of years, that about 60% of them were intracerebral hemorrhages and about 40% were subarachnoid hemorrhages. 60 is close to 40. It's not exactly 50-50, but maybe we can do a few things just grouping around behaviors of hemorrhagic stroke. And that we found most of these patients, were younger than 65, but that looks pretty close to 50-50. Again, if you're looking at observational research, you love when the numbers are about 50-50, because that gives you groups to look at that are reasonably sizable, right? What doesn't, if you want to look at the effect of pre-injury, warfarin, well, that's a little trickier when only 10% of them are taking it. Right? B stuff, whoops, all of this. Right? Now, we always follow the guideline. The guideline says to start within 72 hours, and what's this graph? This doesn't look like what we actually do. It's amazing. Again, you can observe a lot just by watching. And if I asked any of you, right, what do you do in your hospital? Well, we do this. And the answer probably is that when you do this, it actually looks like this graph. So 72 hours would be sitting right about here. So 100% of the population is covered by that. Does that little pointer come up on this? Oh, I have to do this, huh? Where's my microphone? I stole it. Right? So everybody should be done by here. Is this kind of clear what's happening? And then there's a whole bunch of stragglers here. So something's really up. This describes everything. This is practice variation. Now, what happens if you were going to get some kind of venous thromboembolic problem, a DVT or a pulmonary embolism? Well, look at that. So you would divide these into a couple different groups. If by 72 hours they should get it, one would say that these people, it's unpreventable. So what's interesting here is our fear is of bleeding, but the reality is we have a bunch of people who show up to the hospital with pre-existing clots. And they're bleeding. Oh, it's so confusing. And then we would look at this group out here and we'd say, wow, these might actually be preventable. This is more than that 72 hours. You just did this to confuse me. Get in my exercise machine. Now, when do people bleed? Could we at least reproduce something that other people had seen before? And it's the majority of your bleeds are going to occur in the first 22 and a half hours for expansion of these. Yes! Some of our patients read the textbook, but still not all of them. Some people still, and here there's probably some other reason they're bleeding again. Notice where this little separation looks a lot like the previous one I showed you with that second group of getting them, which makes me just kind of wonder that they got them. Well, I don't know. We have to look. It's observational research. I can just show you and say whatever I want, right? So if you sort of put does it make a difference about the stability of their follow-up scans? Oh, wait, I started over here last time. You people are getting too much attention. Right? Is that if your follow-up scan is unstable, the time to subsequent progression, well, it's already bled once. And the reality is there's a few people who still will continue to bleed. But even if you have a stable scan, you didn't re-bleed in that first day, you still are at risk to re-bleed. There were no guarantees in that first 20. Well, we're using the information gained on the first scan, and if there's stable hemorrhage, then we get, but it doesn't help you. People still expand their hemorrhages later. Remember, they've got to be 0 in that 0 to 1 because they were stable then, right? They didn't re-bleed then, by definition. All sorts of things hidden in here. You bored yet? Anyone awake? Okay. So the reality is, whoa, look at that, 47.8. That's really close to 50. Yes. All right? So that's about half of the patients at some time expanded their hemorrhage, and about half of them didn't. Right? And about a third of them expanded their hemorrhages early on in that first day or so. So this is a common occurrence. And you can see why people would be confused. And we agreed with the rehab literature that about 11% of these patients develop venous thromboembolic disease. That's a lot. That's like, look at, what do we got? 3 here, 5. I need a table with 6. Yeah, you get the idea. I mean, you know, somewhere in here, 1 in 9 patients, I mean, look around, a bunch of you, right, are going to get this. And what was the reality is only a third of these patients got pharmacological thromboprophylaxis. But that other thing that I'm talking about, notice that 47.6, that's close to the number. Yeah, had it interrupted. So if this is like, well, start, stop, maybe, well, let's just look at dead people. Because we can be sure what happened there. This is not a discussion of the certainty of death. We're calling them dead. They died. I know the outcome is the point here. No gradations of neurological outcome, no gradations as this of clinical importance, this hemorrhage, or right? We're done. And the reality is it didn't seem to make a difference if you didn't have any progression overall or any. But what was important is whether you had clinical deterioration. Now that seems to make sense, right? If you clinically deteriorate, you know, that's the ultimate clinical deterioration, right, is death. So, but there's still 10% of these people who did not have any kind of clinically important progression that still died. Right? Is that because either one of these diseases is a measure of, there's other diseases that go with it, you know, you died from pneumonia, that's beyond what we're looking at here. No, this is of the mortality in those who had clinically important, the other way around here. So if you had clinically important progression, 27% of those people died. And this was statistically important. So if you got worse, you essentially tripled your chances of dying if at any time you get worse. Well, that's good to know. Right? That says up front this is other issues, right? Up front, we should keep you from getting worse the first time. And if you get worse and you triple your chances of dying, you know, we have to think about once you start to get worse is the train out of the station, but that's another talk. You see how this all builds and how you can almost make a career out of this? Almost. So, what did people do? Back to this. Now, remember this graph where everybody gets prophylaxis by 72 hours at this institution. Yeah, right. So the reality is we're really good with squeezy boots because, you know, how could that hurt anyone, right? And so the less uncertainty that's there, the more likely we are to behave in some fashion. So nobody's afraid of putting boots on the legs, making the brain bleed. So that's easy, right? And we still had some patients that got IVC filters, but I'm not going to go there. Bottom line guideline says no unless you can't tolerate these other drugs. Right? And the reality is that only a third of patients, well, everybody in our place gets, only a third of patients actually got heparin or low molecular weight heparins. And since they all get it within 72 hours, according to the guidelines, remember, my co-authors and we sat here and, you know, I made sure this is all cool with them. Because in some ways, you could sit there and go, well, God, why does Dr. Malik have this guy here? Look how stupid they are there. This is how the world works. I mean, I spent 17 years, you know, presenting stupid at another institution. But, right, what do? We use this to study, and we then use it to fix. And here's what's really interesting to me is that 39 is to 81 as 1 is to 2. close, maybe 50%, close enough, maybe 39 of 81, maybe. Interrupted, start and stop, start and stop. And once you start and stopped, you didn't just start and stop once, you start and stopped a few times. So something is about, right? Squeezy boots, no problem, put them on. Drugs, well, they're called for, but clearly there's consternation and confusion. So, well, was it just inherent that physicians were behaving differently because of what the disease was? And the answer is yes, if you had aneurysmal hemorrhage, you were more likely to get the drugs. Well, that seems like such a bad disease, right? But we took care of the problem. Clip, coil. Is it because you were comatose? And the answer is yes. Well, so, you know, they're lying in bed, they're more severe. Maybe we should be giving it to them. And then we were, versus the argument, well, that's really far gone. That I can't assess him if he's any worse. That didn't seem to be the argument people were using. Older people did not get it as often. More severe strokes, more likely to get it. Well, he's paralyzed there. So inherently, we're using some of this information on severity, one might suggest. And surprise, right, this is just internal check. You're wondering, what does length of stay have to do with it? Well, the longer that you're in-house, the more likely you were to get it. Well, that just seems to make sense, because you're there for more things to potentially happen to you, and the longer you're in the ICU. But what's interesting is it didn't matter whether you were taking rat poison beforehand. It didn't matter whether you were walking. I mean, all sorts of things I can show you here that didn't matter, but why bother you with that? Is it lunchtime yet? Well, I had to stop. So the bottom line is the more severe you were, the longer you were there in particular. And the reality is that severity thing, once we adjust all those statistical things that I don't, not now. That it was basically the longer you were, well, you know, the risk. Now, is that because physicians thought the risk increased? Is that because every day the nurse is hounding the physician? Excuse me, pig intestine extract, excuse me. That's where heparin comes from. Most of it in this country is extracted from, think about it, where it's got to come from, right? In the intestines, very small capillaries. We don't want them to clot off. We need to absorb nutrients so we can become overweight and get Alzheimer's, right? You think I wasn't paying attention this morning. But you had every day you were in the hospital, right? Another 1 out of 9 people got drug, right? Actually, it had nothing to do with the nurse. It was probably the pharmacists. Ooh, wrong audience to say that. Now, what fascinated me, though, is in all of this, and this is really what dragged me into this study to begin with, is why do people start and stop? The reality is that people started and stopped if they have intracerebral hemorrhage. There's clearly something that bothers us about intracerebral hemorrhages, right? Aneurysms, you know, in comes Dr. Malik on his white horse, you know, Dr. Osborne leads a charge, you know, coil this, clip this, no, neither, yes, both, it's taken care of, right? Whereas, well, you know, where did it bleed in the brain? How do we stop that from doing it? And that probably leads to confusion, right? Younger people were more likely to get stopped and started. I don't know why. Please don't ask. See, this is where I can hide on observational research, right? And that length of stay, right? So the longer you're in the ICU, well, maybe it's because, well, he's going to have this procedure. Oh, hold his heparin, he's getting a peg. No, we're going to put a new central line. All right? The bottom line, and I know most of you are nurses, is, right, this got to drive y'all nuts. Well, he got it today. He needs to get it tomorrow. I don't. drive me nuts. So, does it make a difference about when we give these drugs, does it make a difference when you get it? Now remember, this is when people get their VTEs. Right? Nothing up my sleeve here, showed you this before. Right? And so any kind of clot was essentially kind of an 8 point, don't worry about this, 11%, as I said. Because some people got multiple clots when you go looking, but there were only 3 PEs in the whole thing. So does it make a difference? What was the setup for getting it? And then we'll get to whether the drug makes a difference. Well, the reality is the more severe you were, the more likely you were to get it. Well, you were also more likely to get drug. Remember, we just showed that a few minutes ago, those who were napping. And if you were ambulatory, you were less likely to get, well, that's good to know. Things that, things we expected occurred. And you were more, if you were using warfarin before you came in the hospital, you were more likely to get it when you came in the hospital. You were probably taking the warfarin for a reason. And again, that longer you are there, the longer your risk is. So you can see some things. The longer you're there, the longer you have a risk to develop it, the more severe your injury clinically, the more likely you were to get a clot. You were also using those things to more likely to get drug. So now, does it make a difference whether you get the drug, and does it make a difference? And the reality is that, yeah, you should get it. It looked like it's lower, right? Your odds ratio is about 4 to 1, right? But it's all over the place when we looked at whether it was because it's interrupted, it's continued. So wait a minute, 4 to 1, Bill, you mean it's a 4 to 1 reduction in risk? No. You were 4 times more likely, almost, to get a clot if you had drug. Well, that doesn't make any sense. What? Well, it means that any is just overall, but does it matter when you get it? And the reality is if we give it before you developed your venous embolism or your thrombosis, no, it did not increase it. You confused? So are we. So now we got to look at all sorts, don't worry, it's statistical stuff again. Show nice graphs and charts instead. So exposure to the drug designed to prevent clots was associated with developing a clot. Now, what I can't, did they develop the clot and then get the drug, and that's why it's, okay? And older people got clots. Well, maybe this was because, we're going to take a step back for a minute. Maybe this is because inherently physicians were practicing correctly because of the risk of expanding their hemorrhage. How am I doing on time, by the way? Darn, I wanted to be done. So did hundreds of people out here. Okay, remember this now. This is like, days from your admission until you have some progression, right? And about half the people didn't, and about half the people did. Easy enough. And just because your follow-up CT was stable one day didn't mean that you weren't going to progress. Again, inherently, that's what's in the guidelines. Use that information. If you're stable, go ahead and give the drug. But that's the beauty of natural history studies. So, does it matter? Well, remember about 47% get clinically important thing. And what was the most common thing that we saw was that they just got sleepy. So physically, there is a role for physical examination. There is a role for continual nursing care. There is a question mark, what do you do about, do you wake people up every 4 hours a night and then they're sleepy because, again, bigger issue. So, what does it? So what might be behind this? So, is getting the drug more likely to make you bleed later? And the answer is, it doesn't it's just the longer you're there. And all of this may just be pointing to the longer you're in hospital, you have more chances for something to happen to you, either good or bad. The longer you're in hospital, you're maybe there because you're sicker to begin with. So is it just that you're sicker that leads you to have more procedures? You get the intertwining of this. You want to know why there's no straight statements in any of these guidelines? Are you getting the picture now? So, hemorrhage progression, and did you get the drug? Well, the answer is yes, there is an association. Drugs that make it harder to maintain clots or prevent the formation of clots are more likely to make you bleed. Duh. As my daughter says, WD. Anyone else have teenage girls here? My condolences to all of you. Now, skip this unadjusted, so let's get to the real thing. So what's the bottom? Is it getting, when we adjust it, though, for all the other facts, the answer is no. It doesn't seem to be the reason because you got the drug. The drug, you may be associated, you get drug, the longer you're there, the more you have clots, et cetera. But is the drug causing the clots? And the answer is, it does not appear to be so. Whew. That would have been bad. Now, males, et cetera, but in the interest of time, I'm going to keep going here. Now, what happens when you're using that information that we use to guide our behavior, and it says, whoa, the hemorrhage is larger here, don't do this? Well, the reality is that only one patient received it after seeing that unstable thing. So we still said, well, that CT scan's unstable, but you're still getting it. Therefore, I can't tell you a darn thing about this. So finally, where there's two things in the guidelines that my hospital seemed to follow. Number one, squeezy boots, no contention. Number two, still bleeding on day one? Don't give them the drugs. Well, it's good to know, but I can't look at it. And so the bottom line is that any predictor, right, subarachnoid hemorrhage patients were more like, well, that's why we go to secure the aneurysm. We're not discovering anything new. We try not to let people, we try to follow a policy. I don't know if it's just similar to yours. Not later than the morning after admission. You want everybody to be well rested, hopefully, et cetera. So what does this all mean before you all fall asleep? Well, so the bottom line in this observational study, right, is that in hemorrhagic stroke, there's clearly something other than guidelines. There's clinical judgment in some fashion. And it was relatively infrequently used. It wasn't no 100%. We seem to be much more comfortable with aneurysmal hemorrhage patients than we are with intracerebral hemorrhage patients. But it's not clear that we have any reason to be uncomfortable with intracerebral hemorrhage patients. See, I could have skipped all of this and just talked about this. Right? It's clear that we're we seem to be more comfortable giving these drugs to younger people. We seem to be more comfortable giving them, or at least it's not necessarily comfort, we feel more drive, perhaps, to give them to patients who have more severe NIH stroke scales, more severe Glasgow Coma Scale scores. So the worse off you are, the more compelled maybe we feel to prevent venous thromboembolic disease. And the longer you're there, the longer, if you will, there's more chance for the physician to be influenced by nurses, pharmacists, or there's more chances to think, ooh, I forgot to do that. And there are several things that we thought, might influence it, but it didn't matter whether you were taking rat poison before you came in, right? If you were overweight, if you were walking or not, etc. The only thing that seemed to make a difference, in fact, was how long were you, the longer you were there, the more likely you were to get treated. So we don't seem, in other words, if it's near 50-50 that you're getting treated, and this clinical judgment issue, the bottom line is that only the longer you're there were you more, because you get more coin flips, right? Each coin flip's independent, it's each 50-50, right? Odds never change, but the longer you're there, you just get more coin flips every day. And the issue of interruption is that the longer you're there, you have essentially a 1 in 7 chance that it will be interrupted, particularly if you're younger, because, and again, observational, because there are procedures being done, because he's bleeding, because, right? But that you may start it. So the reality is that symptomatic DVTs are somewhat common. The rehab literature is about right when you go looking, is about 11% of these people, right? But it doesn't look like it necessarily, in and of itself, kills you. You seem to be those who were more severely injured, higher stroke scales, lower Glasgow Coma Scale scores. That makes sense, right? You were more likely to develop it if you were taking rat poison before you came in. You all know that warfarin is what's in American rat poison. Okay. Canada still has, I think, still has thallium in some. So if you ever see a dead rat near the border, like in Detroit, where just kick it. If the hair falls off, it's probably thallium, and if it bleeds all over your shoe, it's probably warfarin. So there are a lot of things that seem to inherently be followed, right? Your risk of the drug getting, the risk of getting a clot increases as you're more severely injured and the longer you're there, but your chances of being treated as well. So what do we do with this information? And if the statistical stuff I didn't want to bother you with today in great detail, you can read it in the publication in Stroke whenever it's almost finished, is, does this drug work? And the answer is yes. Your odds of developing a clot are about 95% lower if you're given one of these drugs. That's good. Right? And it doesn't seem to necessarily kill you. So overall, do these things work? It seems to be the case. Because hemorrhage progression is not something to track in and of itself. It's pretty common. It's nearly a coin flip. And once you've had progression, it's a coin flip whether you got worse. So, and once you get worse, the cat's out of the bag, it looks like, because you get sleepy and you tend to die. So, since you can't predict that the drugs are going to cause that worsening, and you can predict that the drugs are going to save you from clots, and clots seem to kill, well, maybe there's rationale for doing this. Those wise men and women at the Heart Association weren't so far off to begin with. And if it's 2/3 of them have a stable CT and a third don't, that it doesn't seem, again, in summary of that, it does not seem to be that you're going to bleed later on because you get the drug. So it seems safe, it seems effective. Well, that's great. So why have I wasted y'all's time? Because I'm up here echoing the wise men and women of the Heart Association and have a lot of information to go on. But if your stroke is stable, there's no reason not to do this. So right, you can take these data, process improvement, right? The reason to do this kind of research. Now I can take these data back to all of our practitioners and nurses and pharmacists and everybody and say, look, don't be afraid. Come have a big hug and realize that this stuff works and it's safe. Kumbaya. right? This is great. What's the bottom line, though, in terms of the 72 hours? I don't know. The exact timing is really unclear. And there's nothing to suggest that you can't start it that same, not later in the morning after admission. So guess what I do? It seems to work. It seems to be safe. Yeah, why not just give it the next morning? Right? And the real thing you want to know is if your CT is unstable, I unfortunately cannot tell you that that's really an exclusion because everybody was using it as an exclusion, as I showed you. So I can't tell you whether we're just being crazy and just because your CT looked worse the next day that you can't get the drug. So I really only have 2 words for you. I'm sorry I can't tell you that, right? So the uncertain situation remains even more uncertain because I also can't then tell you how many more days do you need to be stable before. I'm also sorry for wasting your time. I'm sorry for so many things. And you'll probably agree with my teenage daughter that I look better on paper than in person. I thank you for your time. Go eat lunch.